Good morning, everyone. Good morning. Caitlin, can I ask you to turn on your camera? Great, thank you. Thank you, everyone, for joining us. We're here for an exciting and innovative session focused on child and youth social prescribing. So our presenters are going to be sharing stories, research, practical strategies for implementing social prescribing programs. So I think we're all going to be introduced to some new thinking about how to serve children and youth. All of the stories, I think, highlight the power of social prescribing. And then after the presentations, we're going to do a panel discussion and Q&As in the chat. Cynthia's with us today, so she's going to be collecting those questions from you as well. So thank you very much. I'm going to pass the floor first to Caitlin Mall and Dr. Sue Bennett. I'll introduce them from the Vanier Social Pediatric Hub. Caitlin is a PhD candidate in health quality at Queen's University. She's also the social prescribing advisor at the Vanier Social Pediatric Hub, a research assistant at the University of Toronto on a study on the co-production and social prescribing, and the co-founder and co-lead of the Canadian Social Prescribing Student Collective. That's why many of you here will recognize her face. And then we also have Dr. Sue Bennett. She's a full professor in pediatrics at the University of Ottawa, a pediatrician, the director of social pediatrics at the Children's Hospital in Eastern Ontario, CHEO, and the medical director of the Vanier Social Pediatric Hub in Ottawa. She is the co-principal investigator of the PHAC Mental Health Promotion Innovation Grant, and they are developing, implementing, and evaluating the first social prescribing program for children and youth in Canada. So I'm going to pass the floor to Caitlin and Sue, and they will start their presentation.
Thank you so much.
Good morning, everyone. Welcome. Bienvenue. You've had our introductions. We only have 15 minutes, and I know Caitlin and we could wax eloquently for hours. We're both very passionate about this initiative because it's quite unique. So we will have question and answers, but we're going to move quickly and efficiently through the slides, and we'll be open to questions and discussion. Looking forward to that. Okay. Caitlin's moving the slides. For the next slide. Okay. So I'm medical director of the Vanier Social Pediatric Hub, which provides integrated health and social care for inner city children in Ottawa. And it's a unique model of care based on Montreal pediatrician Dr. Gilles Julien's model of care. There are about 40 plus centers in Quebec, and we were the first one to implement this model outside Quebec 6 years ago. I'm going to give you a picture shows 1,000 words in the description of the model of care. So we've got a 2-minute video we're just going to show you from his website. Thanks, Caitlin.
Melissa is 10 years old. Her life is not easy. She shares a chilly, unhealthy apartment with her mother and little brother. She always has a cold. Her mom works at night and is seldom around to take care of her. Her father's behavior has been violent. The authorities have ordered him to stay away. Resources are scarce. A youth protection worker is already involved with them. Melissa doesn't sleep well and has dark, suicidal thoughts that worry people close to her. She cries a lot at school and doesn't pay attention in class. Her marks are terrible. She has recently developed behavior problems and is often absent from school. Her teacher suggests a meeting at the Community Social Pediatric Center to find out what she needs and to set her up with coherent services. In order to come up with an overall picture of her health, the social pediatrics team bring together Melissa, key adults, and professionals already involved with her. In an informal setting, Melissa's voice is finally heard by everyone, and each person describes how they are involved with her. everyone becomes aware of the difficulties Melissa faces. Many of these problems prevent her basic needs from being met and her rights from being respected. The meeting also highlights Melissa's many strengths. She is sociable and assertive. She is a very responsible child. She clearly expresses her wish to succeed in spite of the obstacles and shows a lot of interest in drawing and music. A range of resources are mobilized to get at the root of Melissa's difficulties and tackle the obstacles she faces. The doctor diagnoses her various problems. The social worker gets involved with Melissa's mother to find better ways to support her daughter. The lawyer provides assistance to address the problem of the unhealthy apartment. The art therapist helps Melissa to better understand her emotions. Volunteers help to make the most of her potential through drawing and music classes and lend a hand with homework. External partners are also on board to provide other essential services. Just like Melissa, thousands of children are at risk and face many obstacles harmful to their health and development. All these children will grow up to become adults who are expected to contribute to society. Community social pediatrics aim to provide all children with the same opportunity to develop their full potential. They will then be able to take their place in the world on an equal footing.
So, social prescribing at the Vanier Social Pediatric Hub. As noted, this hub enables access to comprehensive integrated health and social services to children and youth and families living in disadvantaged services. You can see eligibility. Our kids are 0 to 17 years of age. They have to live, for the funding purposes, the limited funding that we have, to live in Vanier and go to school in Vanier. Actually, it's not just because of the funding. That's one of the primary reasons, but it's very important, the neighborhood, for accessibility, for walkability for our families. And the referral is for the kids who have complex psychosocial needs. We're not doing primary care. So it's an interdisciplinary team. It's a kitchen table model where everybody sits around the table. The child brings their supportive caregivers and any other professionals involved. Oftentimes the school are there, but they can bring anyone. And we have our multidisciplinary team sitting at the kitchen table in a strength-based model with the child as the primary candidate at the table, and we get to know all the family and ask how we can help them. It's a very different approach from the medical model. Okay. Vanier, for those that don't live in Ottawa or are aware, it is on all demographics a vulnerable community, low income, high needs. It's a Francophone minority population, as well as we get a lot of the newcomers, the refugee immigrant population on the Francophone Africa, for example, the new immigrants coming in from Syria, the Middle East. And it's well known in the child protection services for community violence and gang-related activity. It is on socioeconomic, quite clearly, mainly low-income community, although there is some gentrification going on. So it is really one of the most vulnerable communities that we're approaching with our services. Okay. So several years ago, we received, 2 years ago, I think it was, $500,000 from the Public Health Agency of Canada from their Mental Health Promotion Innovation Fund to develop, implement, and evaluate Canada's first social prescribing program for children and youth. And actually, we've been open at the hub with actually this perspective of social prescribing, but very much in an informal way. But that is all about social pediatrics in the community, matching up very well with our social prescribing. So it wasn't such a big step for us to implement this. Okay. We actually started in June. It took a lot of preparation. We can move forward whenever. Yes. So just to say, we started in June of this year. So we've been up and running in the formal implementation, and the evaluation will be taking place in the next couple of months. So at the heart of the work we do at the Hub, which is based on the United Nations Convention on the Rights of the Child principles, where children's participation and opinions and perspectives are absolutely basic for our work. Anything that is involving children, they should be able to participate and give their opinions. So at the very start of pre-implementation, we asked the neighborhood's children, what would they like to do? What would bring them joy? What activities? It was just an open-ended question. This was last November. And we had 200 children give their opinions, what they would want. And we've got this word cloud that gives you some ideas. And soccer was not surprisingly primary in view of the World Cup taking place in Qatar last November. But there are many other activities shown as well. So this was one of the first steps. What do the children want themselves? Okay. So how does it actually work, the social prescribing program at the Hub? I've already defined the group of children, the population. So our Hub multidisciplinary team identifies that the child and youth has non-medical health-related social needs. This is part of our general assessment. Of course, we check out medical health-related needs as well, but social needs. The child and youth meets with the connector. Now, at the beginning of our program, it was a social worker. We were connecting, the connectors were the social workers. They're called link workers in the UK. And at this meeting, which could take up to an hour, we plan for an hour, the connector connects the child and youth to non-clinical supports and services within the community. There is, before that, a co-production. So just to be clear, the connector meets with the child and there's a co-production of the social prescription. What is it brings joy to the child? What would they like? It really isn't like the prescription of a physician prescribing what is needed for that person without discussion with that person. This is co-created in that meeting. And then the connector connects those activities with what is available in the community. So this is the prescription. We actually give the child a written prescription of what those activities are. And you can see in the photograph, the following photograph, they're very proud to have their own prescriptions, and there'll be follow-up with the connector within days to get that connected up. There's many barriers that might come along with transportation, with funding issues, with connections with those activities in the communities. There's a lot of work that goes on there, but the children are in charge. This is their prescription and this is their joy. Of course, we're very careful about protection of our children, thus we can't see fully their wonderful, happy faces. This brings a lot of joy to the families and the kids. Okay, I'll hand over to Caitlin now.
Thank you. So you might be wondering, how do we get to that point, the point where we're giving out that social prescription? How do we actually figure out what sort of social prescription might be a good fit for them? So one thing that we did was partner with an organization in the UK called Me First, and they are experts in child and youth-centered communication. So we did a 2-day training for our connectors, and we also collaborated with them to make their tools into French, so that we have French and English tools for our program. And this is one that we've really been using a lot to pull out what it is that matters to our kids. So this is 3 houses. The first house is the house of worries. the second house, house of good things, and the third house, house of dreams. And the connector and the child or youth work together to fill out this tool and to figure out really what it is that matters to them. And you will see on the next slide here, this is just one example. You will see here what the child has filled out. And one thing in their house of dreams was gymnastics. And so you'll see their social prescription is for gymnastics. They just got that last month, and they're just about to start a gymnastics program in November. And you'll see too, this is different from a traditional prescription as well, in that it's not just a health professional who is signing off on this. This is something that was co-created by the connector and the child. And so they both write their name and they both sign it to show that this was something that they've created together. On the next slide here, you will see some of the wonderful activities that they participated in. And this is just some of them. For example, we have some children about to go on Dreams Take Flight. So they go on a flight very early in the morning, go to Disney World for the day and come back all in one day. They are doing such incredible things. And this is just some of it here. Next slide. I'll just very, very quickly highlight the barriers that we are addressing to ensure that our children can fully participate in this program. So we conduct the sessions in locations that work for them, whether that be at home, virtually, somewhere in the community, or at the hub. We also offer to accompany them to their activities. So the connectors will do that if it makes them feel more comfortable. And we've also worked very hard to strengthen existing community partnerships and develop new ones to be able to offer free or low-cost social prescriptions. We also ensure that we are able to cover the cost of social prescriptions that are not free, but through our partnerships, we've been able to create really great opportunities that don't come at a cost. So thankfully, we haven't had to do this very much. And transportation is a very big barrier as well. So we have funds set aside to be able to cover the cost of that. And this is our incredible list that we are very proud to share. All of these organizations are supporting us by providing either free or low-cost social prescriptions. And we're very thankful for every single one of them. And we'll just end off with this picture. We had the opportunity to meet with Dr. Michael Dixon and Dr. Marie Pauley, who really kind of started this social prescribing movement in the UK. Dr. Michael Dixon is actually now the King's physician. So it was really kind of great to be able to talk with them about what it is that we're doing here in Canada. And that's everything from us. Thank you so much, everyone.
Thank you. We look forward to your questions.
Thank you, Dr. Bennett. Thank you, Caitlin. I think that opening video was very powerful and very touching. And you are doing such important and deep work. So thank you for that. I'm going to introduce now Renee Young from Gateway Community Health Center. So Renee is the community coordinator at Gateway in Tweed, Ontario. She's a registered early childhood educator. She's passionate about early literacy and outdoor play. Renee is excited about helping a community leverage its strengths and to support local families and young children. Renee and her team are always learning about new and creative ways to support and provide programs and services in their area. Thank you very much. Renee, if you want to start your presentation now, you can take the floor.
Sure. Is it showing?
There we go, Renee.
Okay. And can you hear me? We had some problems.
Very well. Yes, no problem.
Okay, great.
Maybe you want to put it on presentation mode and then we can see the screen.
There we go.
Perfect. Great.
Okay. That was a really inspiring presentation, Sue and Caitlin. That's really amazing. anyway, we can talk another time. That was really fun. We are, as we said, we are in in Tweed, Ontario, Gateway Community Health Center, a small rural area in Central Hastings. We are part of the Hastings and Prince Edward County, which is a huge geographical area spread out very far, and most of the resources are in the south. So we are centrally located. And I was supposed to have my coworker Kate with me today. She's also an ECE, but somehow we planned an event on the same day as today. And great news. She actually has a few classrooms coming, and they could come at their lunchtime, which is right now. So she apologizes for not being here. So I thought I would kind of just go through our thought process for how we kind of came up with our project. And, I'll fully admit, I always look at everything through a family early childhood lens. So when this came to me, that's how I went at this for. It's always been a goal to promote early childhood, healthy early development within our center. I've worked, we're lucky enough to have an ECE position here. So it's something we've worked at for a long time. We did some training over COVID, which I'll tell you about. That really helped us highlight it or bring some more focus at our center to early childhood. So that's where I started. And then, of course, we consider the parental supports that are available. Prenatal, we don't have that anymore in-house. It's only available online through public health. Postpartum, there's no formal groups available really in our area unless you want to go virtual. Parenting support, families can access PPP, but not like what you might see available in a bigger center. And then, of course, very often there are grandparents involved in the care of a child or surrounding that child. And, quite often when we think about social prescribing or think about lonely and isolated, we think about seniors, and that is most definitely a large part of our demographic. But what that helped us do is when we think about grandparents, that brings us right back to the child and the lonely, isolated. So anyway, we came up with the question of why don't we try to support all of the generations somehow. So the little question is there, can we improve the well-being of multiple generations by starting with the healthy development of the child? And the next slide, I guess, is just a bit more formal. This is the question we try to keep ourselves focused on, because like you said as well, Sue, social prescribing has happened in our health center. It always has been happening, but this is a much more formal way of tracking it and really trying to follow what the impact is. So we want to keep ourselves focused on the child and their family. So we're starting with the child. That was our focus, starting with the child. And this worked really well with another kind of project goal that we had with having our children fill out the ages and stages questionnaire. So this is directly from the ASQ website. ASQ website. It is a developmental screening tool that pinpoints developmental progress in children between the ages of 1 month to 5.5 years. So just before actually the training began, or we were part of the pilot project in 2019, and then COVID really interrupted it. But we managed to finish all the training. We're at the very final end of the project, but we were fortunately part of a pilot project through Infant and Early Mental Health Promotion that was provided through Sick Kids in Toronto. And many ECEs, early learning organizations within Hastings County, participated in this training, and we were trained on implementing, scoring the ASQs. and then creating developmental service plans for families. That's just really quick on that. It's a lot more, but it works out well. So that was our starting point to get to start with the child using the ASQs and then branching out to the families. So this is our plan. It seems really simple. It's 3 steps, should be easy. And I can talk about a lot of pain points that happen in there, but you know, some of it, there are also referrals from our primary care side that we would also insert into this process. But essentially, yeah, we would call our families, invite them in for an appointment to do the ASQs, talk about the ASQs, and you know, invite parents, guardians to come in, and then we would actually invite anybody that was involved in that child to come in and let's talk, let's discuss what everyone's needs may be, how do they think they could better support their child, and then what social prescription can we provide for them. So being in a smaller community, we do have many assets. There are lots of things happening. You know, there's some sort of festival happening in Tweed almost every weekend. People have done a really great job of creating social events here, but there really is not a lot happening for young parents, babies, or children in early childhood. I can go on the next slide. So our library does amazing work, has phenomenal programs for almost all ages, except for really early childhood. Foundations for Youth, there's a local organization. There are service organizations, Lions, Kiwanis. So the early on has one playgroup in each of our 3 towns once a week. And there are spiritual organizations. And so then the 3 highlighted squares are our own programs. So we have a walk and talk program, which is really open to all ages, but it is mostly seniors that come. And it's just a safe place, indoor space that they can walk using poles. And then they also have conversation and a snack. Reading Stars is a literacy program that is, it is teacher referred, but also very volunteer heavy, which is why it's such a great program. Each child that comes to read with us once a week gets their own volunteer, and it's the same volunteer for the duration of the program. So great opportunity to build relationships, intergenerational relationship, and both parties really benefit from that program. We love it. One of our favorites. And our jazz band. So we are very unique and able to, we have a jazz band. It's kids from grades 5 to 8 are invited to come. You do not need to have any prior experience knowing an instrument, playing an instrument. We hire a music director with experience, and we have the instruments through some previous grants, previous programs. And so it is a social prescription we have at our disposal. So although there are many opportunities here, we weren't finding a lot for especially early childhood and youth. So we created our own social prescriptions. And so one of the great things over the summer, we did quite a few things. And the first one was a strawberry social. And what this did for us also was we got a great response from youth that wanted to volunteer. So there's a picture of just a few of them. There was lots more. You know, Strawberry Social is just, it happens often in small towns, and it's just a great opportunity for connection, for chatting, for grandparents to bring their grandchildren, and even for our staff. It was just a great connection event. There's one of them. We had a bike rodeo with partnerships with the OPP and the Brain Health, local community brain injury service. So this was the best one. We had a stuffy buddy clinic, and it's very similar to a teddy bear clinic, but because of another local event that happens here, we can't call it the teddy bear clinic. And so what we did is we set up a doctor's office, and it was great because we involved primary care. So we made little tickets that primary care could, appointment reminder sheets that we gave to all of our NPs, primary care providers, and nurses, that they could hand out whenever they saw a child to let them know that this event was happening and that they could bring their stuffy, and they had an appointment time. It was such a great turnout. Our local YMCA daycare brought their kids over, and they did a shout out on social media for us. Their group had such a good time. We had lots of community families come out, and we set it up in, they came to triage, then they went to the doctors, had an x-ray, and we had a center that we talked about belonging, having friends, making friends, being social, getting together with friends, a physical activity area, a snack, and then of course a prize. And again, another opportunity where young people really wanted to come help. And it gets started with our staff. We brought our kids, they brought their friends. And that has actually transferred to, we now have more volunteers for the jazz band who are going to come. So just a couple more pictures of the x-ray machine and the light table that we used as an x-ray. So from the Stuffy Buddy Clinic, we also had a milestone check kind of center station where we just talked a little bit about the ASQs and what they are, and how that could support them and how we could support them. And we had a little sign-up sheet. And 10 families signed up for a milestone check appointment to talk about development and for a follow-up appointment. And we're still working with those families, and some of the grandparents have gone to the walk and talk. They volunteered for the Reading Stars program, and children and families have come to the early on playgroup. So that was a real great feather in our cap. And as well as from that event is our Spooky Buddy Clinic is what's happening today. So it's their follow-up appointment at the Spooky Buddy Clinic. And what happened with that is we have 2 schools in Tweed, one Catholic, one public, and they both contacted us, and they're bringing classes down today. So that's why Kate is very busy today. She's without community that would drop in. There are going to be over 100 kids come through the Spooky Buddy Clinic today, with both of the kindergarten classrooms and the daycare coming by. So as I mentioned, some of the prescriptions were to our own walk and talk program, and they have attended and they've kept attending. And from that program, there was an interest in developing a program that we have named Grand Friends. So another opportunity for youth and seniors to communicate and get together, share skills. It's not fully developed yet, but that's the idea behind it. And we have willing participants on both ends of the age spectrum. I think that's it for me. Thank you very much.
That's great, Renee. Thank you so much. Okay, I'm going to ask Caitlin, Sue, and Renee to come back. We've been getting some questions here in the Q&A chat, and I have some here. I'm going to jump into this one because it seems like an important question. What are some of the added complexities or additional considerations when it comes to social prescribing for youth and children as compared to adults? Who wants to go first? Who should I? Caitlin, you look like you're ready.
Sure. Yeah. I would just say the first one that comes to mind is that the connectors are not only dealing with their child or youth, right? It's a whole family approach. And, just from the simple things of actually getting them to the hub or coordinating with what time the connector is going to meet with them or something like that, or getting them to their social prescribing activities. It's a whole family approach. It is not just for the child or youth. But I'll let the others add to that as well.
Sue, would you like to go ahead?
Yes, I would totally agree with that because the parents have to be on side. We are dealing with a very vulnerable population, and many of the families have a lot of stresses, very busy, chaotic lives oftentimes. So the kids may be really enthusiastic for their prescription, but the barriers we need to experience by the families to get to the activities and really see the importance of that because there are many other priorities that the parents may have. So as Caitlin said, we are addressing the barriers for that to happen. So in pediatrics, we always work with the families. It's not that we work with kids in isolation, but the fact is we're dealing with kids 0 to 17. We are having the interviews directly with verbal kids, so from 3-4 years onwards. But it really needs the connectors to understand, if they're doing the assessments with the kids, to make the therapeutic alliance and to really have an important, meaningful conversation with the kids. They really need to be trained, not just in social prescription, but understanding kids and having the personalities and the expertise to deal with different ages of kids, different developmental stages in diet, social conditions. So, the training is incredibly important. I'd also say that for the kids, we're finding, if we've got a 4-year-old to say, okay, what would you like to do? Just an open-ended question, which we might do more easily with adolescents. Older kids, they don't know what's possible. And maybe they've just been watching their videos 24 hours online and they don't know what's possible. So the co-creation is really us offering things. It's a different conversation to let them know what is out there because, their experience might be quite limited. But there are some significant differences. And I think the parent piece is incredibly important.
Renee, would you like to add to that about the complexities and the things that we need to consider when we're talking about social prescribing for children and youth?
Sure, I would agree. The parent is key. The transportation and living or being in a rural area, so much of it is you have to drive somewhere to get to the activity or get to something, and also even just availability. That's really hard. I think about your soccer. Does the kids want to play soccer? Absolutely, they want to play soccer. And lucky Tweed has a youth soccer program, but the other two towns don't. And it's a good 20-minute drive to Tweed. So even if a child from Madoc would want to play soccer here, they'd have to get here, and that is a barrier to a lot of families. I think the parents are key. And that the link worker, whoever is that first connection, is so key to starting that relationship. For us too, the ASQs, because we want that to be our starting point, it's hard to. It says, it takes 10 minutes to fill out, which should be able to do in a waiting room, come 10 minutes early for your appointment, but it's always longer and it's always better when it's with myself or Kate, because a conversation has to happen, and that's how you build the relationship. And so we have found that a bit tricky. How do we make them meaningful initial appointments? That's been kind of something we've struggled with.
Right. So it's really reducing the barriers, working with the families, taking extra time, and showing, I guess, the co-design, like you said, Dr. Bennett, Sue, that it's a little bit different. You're presenting options because children don't know what the possibilities are out there. Okay, so it sounds like it is very complex. It is a lot of detail and really understanding youth. Okay, I have another question that's come in here, and it's asking what surprised you or what was unexpected in the implementation of your social prescribing program?
I could say, well, we're working in a non-profit organization with limited human resources, financial resources. So we thought that identifying the connectors, things would just go smoothly from there. They could connect with the activities in the community. But because we only had one social worker at one point at the beginning of this program for 91 high needs kids, we decided that the pediatrician, myself, and a nurse at the program would also take on the role of the connector, so that it doesn't have to be a social worker. As Caitlin can expand on that, it can be many different professionals, as long as they're on board understanding the principles. So that was there. And the other was that the amount of time that it needs, I kind of indicated that earlier on, that once the activity that the child is passionate about wants to do, and we've matched it up with the community one, the amount of time that our already existing staff were taking to communicate with the family, to organize the trip and the transportation and the program at the other end, was taking huge amounts of work. So I'm learning that we need to independently, which is what they have in the UK, have link workers, that we don't have to, at least for us, that we don't have to use our existing staff to do that, because it's huge. And many different lesser trained people could do that. I say lesser trained because they do need to be trained in the social pediatric methods, social prescribing, understand kids, and have all the empathy. So I'm just saying that was something we need independently added staff to do that. And on a more positive note, the joy and the excitement that the kids and the families are expressing with these activities and this program, the joy and the excitement in the staff, the resource staff that we have, and in the community partners. This is a whole joyful experience, quite apart from the medical model when we're looking for problems. But what matters to you? What would bring joy to you? So there's a whole, we do work strength-based, but this is actually bringing joy and meaning to people's lives. So that's been a very surprising, very positive, and particularly seeing it with our partners, our external partners. They're really wanting to come on board when they see. I mean, I don't need an evidence-based research to tell them that this is really important. They're just in their altruistic social accountability mandates for their organization coming on board actually quite easily.
Mm-hmm. It makes staff happy as well. That's a really nice thing. Renee, do you want to comment on those, on the unexpected things? I think you're on mute.
Yeah, I'm not talking yet. I was thinking. Unexpected. I think what surprised us at the beginning was, when we started talking about this project with our colleagues and within our center, we thought the referrals would come rolling in, and that didn't happen. So we had to just promote a little bit more, involve a bit more. We had some of our primary care staff be involved in that Stuffy Buddy clinic, and that's exactly what it did. Is it brought joy, it brought some smile, brought some distraction for a day, and that was helpful for us. No, I think that's it.
Great. Caitlin, anything to add?
I would just say, especially in the social pediatric setting, the line that you usually hear, and even in CHCs, is we're already doing this, right? But I think we were still surprised, to be honest, that, even after launching this, we realized, oh, wow, like this is actually really quite an add-on to what was happening, because to be honest, with the families that are being served, the focus ends up being usually on meeting the basic needs. And there doesn't end up being that capacity to focus on just, the dreams and wishes of the children themselves. And so that's what social prescribing, I think, has brought to the hub, is this focus on what matters to the kids and not just meeting those basic needs.
Great. It gives them a voice as well. That's nice. Okay, so I have a question here about the strategies that you employed to engage parents, guardians, and caregivers in the social prescribing process, and what role do they play in the success of these interventions? So what role do the parents, guardians, and caregivers play?
Well, they're absolutely crucial in our clinical assessments. And indeed, from the very first session, we are building a relationship, therapeutic alliance, trust building with these families. As I mentioned, many of them may be newcomers coming from countries where they've been persecuted, from traumatic backgrounds, for people born here in Canada with the low income stressors and child protection services being involved in many of the families. There's a real need to engage in a very important empathic way, non-judgmental way. So right from the beginning, that is necessary to be able to work with these families. So that's part of our raison d'etre. So building the social prescribing model onto that was quite natural. Building that trust building is really important.
And how do you do that? How do you build trust? How do you bring them closer to you?
Well, we have a transdisciplinary group that we're looking at all the different aspects of how we can help the family. So, for example, the first meeting, the kitchen table model, the question we're asking them, even prior to social prescribing, how can we help you? What is going on? Of course, the child is primary at that meeting, and it might be any negative comments that may be coming anyway. We'll have the conversations away from the child. But they understand that we're there to help them. And we're building different programs to show how much we care for them. And I will just say right at the beginning, when we were running for 2 years and then COVID hit, the same week we lost our funding, and there was one pediatrician and one social worker for all of our kids. And so what did we do? In an informal way, we checked. The parents were at home at that point. The Prime Minister was saying, stay home. The food banks had closed, only for online appointments had to be made. The kids were out of school. How were we going to help these families? So we started to call myself and the social worker to the families to say, what do you need? How can we help you? After about 15 phone calls, food was their basic need. So we connected up with the food bank directly, and I had a host of medical students who couldn't work in the schools to help. And we did a humanitarian effort on a weekly basis, doing home visits for all of our families, providing food in person on the doorstep, 2 meters distance, masked. It was pretty tough in the challenges at -40. But the families understood we were there to help them. Whatever they needed on the doorstep, it wasn't just a food delivery, it was a check-in for their health and social needs. If they needed a computer for the kids or a table, as happened for the kids to work at home, whatever need that the family had, we would be there to, and it was a co-creation. What can we do? That was evidence to the family that we really care. We've built up really strong connections with them. And if they don't turn up, for another example of our practices, many of the families don't show up for their appointments, and we don't know why that is, but oftentimes they're very busy. We remind them the day before, but we will reach out to them, not too many times to harass them, but we will reach out and say, can we rebook? We'll do that about 3 times and then send them an email, something like that. If you're in the hospital, you've been waiting 6 months for an appointment, you don't show, nobody's going to follow up on that. Our medical students continue the More Than Just Soup initiative, the home visiting, on a monthly basis. So all of our families still have the home visits if they want it. And particularly more so now with the inflation issues and high cost of food, they're very keen to see the medical students. They get very attached to the students as well. And it's a really, really good, you can feel it. It's an experiential learning that our medical students receive with these families.
Thank you, Sue. Renee, I'm going to ask you the same question because you're in a rural setting, small town. How is it different to engage parents and caregivers? What kind of strategies do you guys have for that?
One of the barriers of something that you said, Sue, triggered this too, is it is sometimes hard to get them here. But what makes it easier, we will often say, why don't you come to playgroup on Tuesday mornings? The early on playgroup actually takes place in our building. So quite often we can meet them there and talk to them there. But for some reason, a lot of families don't want to come to that group. It's scary, I guess, to walk into a group with a lot of other moms, other kids there. It is a small town. People know everyone. And so we will, again, it is hard. It is hard to have the staff to do all of this, but we will have the families come in just one-on-one, and we'll set up a little play area downstairs, and it's just us, and we can chat and we can talk. We build that relationship. And, and maybe then the next step is we'll pop into playgroup if we know they're coming. We can go for a walk. Something I maybe should have mentioned, but we also just completed this summer a system of a little network of trails behind the center in the forest. Somehow in the middle of town, we have a forest behind our building. And so we have a network of trails that we created there. And it has been such a great way to, let's just go for a walk, and then we can chat and we can talk. The other thing too, especially with the ASQs, if a domain shows that it needs some extra support, and we do a development service plan for them, say, usually it's communication. We really need them to follow through with what's on that plan. We meet again in 2-3 months to redo the ASQ. And that's hard because of those basic needs. Our families are struggling. They're worried about housing. They're worried about food. They're worried about getting their kids to school, dressing their kids, making lunches. Even though the activities we provide for them are you can do these at home. There's no cost to them. This will support your child's communication development skills. Sometimes reading a book or spending 15 minutes talking to a baby face to face, that's really hard for a parent to think about during the day because they have all these other needs. So again, it's just the building the relationship, building the trust, and then they'll trust what you tell them.
A lot to think about, yes.
Yeah.
Caitlin, I'm gonna ask you about, if you have ideas for the engagement of caregivers and parents.
Yeah, I think I just echo exactly what Sue and Renee have both said. So I think I'll leave it at that with this question.
Okay, and Sue, you were going to add something there.
Yeah, just to be explicit about the anxieties that some of the families may be feeling. If they've been involved in child protection services or even not, there's a real fear that if they expose their real dire needs, that child protection there'll be a report made to them, and they may risk their kids being taken away. I mean, that's a sort of a stereotypic view, but it actually happens as well. And many of the newcomers who've experienced trauma from authority figures in their own countries, there's the mistrust there. So we are talking about trust building, but in the face of such dire anxieties and dire needs, it is a reality for these families that we need to try really extra hard for that engagement with them.
They really need it. Caitlin, we're going to start with you as a social prescribing advisor about best practices. So what recommendations or best practices can you offer to other communities or organizations that are looking to implement child-focused social prescribing programs?
Yeah, I think just reaching out to others who have been doing this, we reached out to our UK colleagues and have learned from them and really just looking to your community to make this happen. Like Sue said, we have been so surprised and just blown away by all of these community organizations who have said, yes, we love this. We want to support this. Here, we will give you all these free passes, and, your kids can come to our dance program. Sure. So, just leverage the power of your community, I would say. And the caveat I would say to that, though, is, we are very fortunate, I will say that, in Ottawa to have those resources. And I'm sure, Renee, you can speak to the rural context where, it might not be like that. And so I want to recognize that as well, that it's not always such a wealth of resources like we do have. And, connecting with your kids as well as much as you can to hear from them and incorporate their voices into the process. I think that's super important as well. So I'll leave it with those three things.
Great. There's some questions that are coming in. There's a lot of questions coming in, actually. One of them is specifically about school boards. So do you have connections? How do you build those collaborations? Is there examples that you can talk about?
I would say, we have a really great relationship with the schools near us. Not maybe necessarily with the school board. However, I would say that with the infant mental health training, both of the boards were invited to that, and they both have representation at a different table where we talk about the ASQ and our early learning path. The Catholic board actually trained almost all of their ECEs and staff in this ASQ process. So it's really easy when we're working with a family and that child is going to school that we communicate really well with that teacher and where they're going. And that's been a real asset. But locally with our schools, we have great relationships with the educators, with the administration. And so we are able to use that often. I would just want to add to the best practices too. It is trickier here. It really is, but it does happen as well. I've mentioned a library multiple times because we just have such a phenomenal little small library. But even something new that's happened through this process with the library is we'd like to do a cooking class. What we didn't know was that the CEO of our library did some training as a chef. And so we are starting a cooking, again, working on it, a cooking program for young kids. There's a real gap about grade 4 to grade 6. If you don't play hockey, there's not a lot. So that's the gap we're looking at, is that age range. But I would say it's still strengths-based. You find those strengths, you use them, you build on them, and it works.
And I would echo that, Renee. That's absolutely correct. For the Vanier Social Pediatric Hub, most of our referrals are coming from the school. That's where the kids are. That's where the kids' behaviors, reacting to the stresses in their environment, is showing and displaying. And in the situation in the schools, they're just not getting the special education resources that they need. So they're coming to the hub. We have fabulous relationships with the local schools, such that at the first assessment, if they're the referral source, or even if not, we invite them with the families and child's consent to the kitchen table. So they're at the kitchen table. We have one school where the principal, the teacher, and the resource teacher comes, and they're sitting there right at the beginning at the first assessment. They make the time to come because our place is walkable. It's not too far away. And to have them at the table is absolutely incredible. So the school boards are incredibly important. You need to have them on board because that's where the kids spend most of their time. And for the collaboration with them is important. I just say, for also best practices, if you're planning to have a social prescribing program, you need to have an extended time for development of the program to set everything up. As Caitlin mentioned, the partnerships, we need to know what's in the partnership before we can offer the activities. But there does need to be, if you're implementing anything, you need to evaluate. It doesn't exist in government minds if you don't evaluate. So you need we are so fortunate to have Caitlin Moore, who's our international social prescribing researcher on board. And it's just fabulous to have you, Caitlin, because you're involved in, as I am, with the Global Alliance at the national level, at the student level. But we know what's going on and we know what indicators we need to use. It can be a simple report, but you need to evaluate and then you need to disseminate that report. And the other piece of the best practice, you need your local champions. So we've got our local champions within the hub, in the community. You need the boards of your organization. You need your local politicians. We work very closely right on the same block of our hub. We have our MP and our MP and our MPP, and we're very closely aligned with our councillors. So you need at all levels to get your community stakeholder decision makers on board as champions.
Thank you, Sue. So we've come to the end, but I'm going to ask each of you for just a couple of words. What would you say to the people that are online today that are just starting? What is like one piece of advice from each of you, and then we'll let everyone go to lunch.
I would just say thank you so much for being here. And I really do think that this population really deserves more attention in the social prescribing world. So this is super, super important work. And I hope to see more social prescribing programs for kids in the future.
I've been a pediatrician over 40 years. This is it. I used to run the child protection program at the Children's Hospital of Eastern Ontario and see preventable injuries and reports to Children's Aid without too much prevention. And we are in the business of promoting the full potential, the blossoming of the child within the family, and we're making impacts with our community as well. So it's where it's at. It's where I want to put my energies to make the difference for this generation and the next. Go for it. You asked for a couple of words. I would say go for it.
Renee, and you? I think, yeah.
I'm not sure what I can add to that. Yeah, start somewhere. Start somewhere. And you're right, this population needs more attention, needs more support. We've seen that. I think someone put it in the comments, the mental health of our kiddos and their families is struggling, and we need to deal with it. But go for a walk, go outside.
Thank you. Thank you, everyone. We'll be following up with everybody who registered to the event with the notes, with the videos of the concurrent sessions. And I think Caitlin's put in some nice links in the chat for keeping in touch. And through the platform, you can continue to ask questions and to engage with the people online today. Dr. Sue Bennett, Caitlin Mall, Renee Young, thank you very much. All of you have a really nice day, and I'll see you in the other sessions. Thanks, everyone.
Thank you. Merci.